Thank you, everybody. I'm going to give you guys a little bit more of an introduction. So I am Dr. Kyle Bukowski. I work at Hologic. I'm the medical director of the Women's Health Diagnostics Division. And I'm so excited to be sharing the stage with our wonderful speakers today. Dr. Arlene Senna is a professor of medicine at the University of North Carolina, Chapel Hill, Institute of Global Health and Infectious Diseases, an adjunct professor in the Department of Epidemiology at UNC Chapel Hill Gillian School of Global Public Health. She served as the medical and laboratory director at the Durham County Department of Public Health from 2000 to 2020. She has diverse research interests in novel diagnostics and therapeutic regimens for STIs, including trichomonas, bacterial vaginosis, mycoplasma genitalium, and syphilis. She has been a co-project director for an NIH-funded grant for syphilis vaccine development and the principal investigator for an NIH-supported contract to develop a syphilis specimen biorepository for future syphilis diagnostics. She is a consultant for the CDC STD treatment guidelines and the North Carolina STD HIV prevention and care branch. Dr. Jane Schwebke completed her medical school residency in internal medicine at Northwestern University. She then completed a fellowship in infectious diseases at the University of Washington, Seattle, where she began her research in STIs and vaginitis. She served as the director of the City of Chicago STD program until 1994, when she began her career at the University of Alabama at Birmingham in the Division of Infectious Diseases. While there, she was the medical director for the Jefferson County STD program and continued her research in STD and vaginitis. Over the past 30 years, she has concentrated her research on vaginitis, especially trichomoniasis, and bacterial vaginosis. She's currently professor emeritus in the Division of Infectious Diseases at UAB. So I'm going to let them give their wonderful presentations, and we'll have some time for a Q&A, and I appreciate everybody for being here.
All right, so I'm going to talk to you today about the challenges of STI prevention and control. We'll talk a little bit about co-infections. And so, okay. So these are just a few of my disclosures. I do provide gonorrhea information for up-to-date. I'm also an educator for the Prevention Training Center for Southeastern US, and also I'm on the ASTDA board. So this is what I'm going to cover today. So syphilis is my first passion, but I have to talk about other STIs. So whenever I tell people I love syphilis, I always get a good laugh out of that. Not from personal experience, but due to professional experience, of course. So I'm going to talk about global and US rates. It's really important to paint the picture, and Dr. Marazzo and others from the CDC, our nice colleagues, have already provided us with a lot of that data. I'm going to talk briefly about the burden of asymptomatic infections, very important for us to recognize, as well as some of the screening gaps that still exist. And I'll talk briefly about increased antimicrobial resistance, which you know for gonorrhea, and also mycoplasma genitalium. So just a reminder, of course, the statistics, 1 in 5 people are asymptomatic. So I just wanted to show this vintage poster. I really like vintage posters, but this is a very inappropriate one. Obviously, we don't talk about VDs. We talk about sexually transmitted infections. And of course, probably this woman is made to represent a female sex worker. Obviously, we know that sexually transmitted infections are important for all sexually active women. And also a reminder of the stigma that still exists regarding STIs. So this is a nice figure, and actually a great paper summary from Olivia Van Gerwen and Christina Musney and Dr. Marazzo. So this is a standard World Health Organization map, which they provide on a periodic basis. So what we can see here is 2016 rates. You can see sort of distribution per region. The highest, of course, are in Southeast Asia. There's 108 million cases occurring in Southeast Asia, followed by South Africa. And then numbers on the very bottom of that screen basically shows you the number of cases overall in 2020. Okay, so what about the breakdown per gender? So what you can see here is a breakdown of trichomonas, which is the most prevalent STI, and World Health Organization graphs for bacterial STIs. Interestingly, they put estimate for male, which is higher than females, which is surprising to me because we know that most of trichomonas diagnosis is occurring among women. And then, of course, we have chlamydia there. You can see the distribution, obviously higher rates among women over men globally. And then you have the rates for gonorrhea. And last but not least, syphilis at 8 million. But essentially, obviously, much lower than the other bacterial STIs, but clearly of major significance. due to complications and, of course, the rise in congenital syphilis worldwide. So let's talk about STI co-infections. So this forum is meant to talk about vaginitis, but I want to put that in greater context of vaginal discharge. So perhaps most of the data we get about vaginal discharge is from lower middle income countries where there's still a lot of syndromic management that's occurring. So that means, of course, that individuals are coming to their STI clinics. They don't have the diagnostic test. They might not even do a speculum exam. So they have to think syndromically of what contributes to vaginal discharge. So this is a very nice paper from the South Africans. You can see that they enrolled about 360 women in 3 sentinel sites. So not surprisingly, BV is the most common. You can see actually BV and chlamydia, I'm sorry, that's Candida, albicans contribute about 38%. But STI co-infections were very significant. There was a proportion of 44% STI co-infections in this particular population. Okay, so I'm going to review some of the CDC slides. You may have seen some of these already. Of course, what we know is that chlamydia continues to rise overall. There was a decline in the past year. So we can see the number of rates there, roughly at 495 cases per 100,000. But look at that remarkable rate here for women. 24-year-old, 3,500 cases per 100,000. That is really dismal. And then you can see there for 15 to 19, 2,650 cases per 100,000, as compared to the overall case rate for men and women of all ages. So what is that telling you? Obviously, we have a lot of work to do if we are going to reduce those rates in these women. Okay, so what about gonorrhea? So gonorrhea also continues to increase. We can see 2018 rise relatively. In 2022, we have 194 cases per 100,000. Now let's look at the age and sex distribution. And we can see for 24-year-olds, it's not as bad as chlamydia, but still 715 cases per 100,000 as compared to this number. That's for 24-year-olds, and 15 and 19-year-olds is 525 cases per 100,000. So again, a significant burden of gonorrhea, although cases and rates in men are typically higher. Okay, and of course syphilis, you've seen some slides about syphilis already. You probably may know that previously the male to female ratio was about 1 to 8, but it's dropped to 1 to 4. And our concerns, of course, are rising rates overall for both sexes. Definitely for women, our concern, of course, is congenital syphilis. So in this particular slide here, what I show is the race, ethnic disparity that exists. So what you have is essentially, although most cases of primary and secondary syphilis are occurring among whites, the rates are highest among Native American and American Indians, followed by blacks. Okay, so now let's talk about asymptomatic infections. So again, you have to go back to data from lower middle income countries to see the burden of asymptomatic infections. And so this is a very nice systematic review and meta-analysis that was conducted by the French. They looked at 48 articles overall. And what you can see here, the proportion of asymptomatic infections. So proportion of asymptomatic infections per 100,000 infected women was 61% of those women were asymptomatic. 53% of infected women with gonorrhea were asymptomatic. And 57% of those with trichomonas infection were asymptomatic. So a heck of a lot of asymptomatic infections. The prevalence is here in this particular table. That's prevalence of asymptomatic infections per women who were tested. Okay, so we're all probably familiar with the U.S. Preventive Task Force recommendation. We've talked about this already. It is important, of course, to screen women less than 24 years of age for gonorrhea and chlamydia, and also women 25 years and older who are increased risk for infection. But unfortunately, how are we doing from a U.S. standpoint? So this is a paper that was conducted a study looking in 2018. These are US Medicaid claims. So what they found was that non-Hispanic blacks, well, overall, there was actually only like half the people had these claims. So that must mean that there must be missed opportunities. So non-Hispanic blacks had the highest percentage of claims for both gonorrhea and chlamydia for those 24 years of age, but clearly the numbers and proportions are not 100%. So we have a ways to go. Okay, so just one word here about screening. So I think we have to recognize, although we're recommending universal screening for those 24 and younger, for women, sexually active women, for gonorrhea and chlamydia, what about rectal screening? Because we know that a lot of the assays are not coming out with rectal screening. So this is a very nice, provocative review, I would say, by the Australians, looking at controversies. So there's many different controversies that they discuss. One of them is, should we be doing extragenital testing to reveal missed infections? So this is among women and men who have sex with men. So the pros, of course, as we know, is that chlamydia can occur at pharyngeal and rectal sites. And then, of course, we know about the untoward consequences of missed infections. However, the cons which they raise is that rectal chlamydia might not always reflect a true infection. Perhaps that means urogenital infection and there's just contamination of the rectal area. And also, we don't know that we don't have enough data regarding the impact of both oral and rectal infections in women. Okay, so I'm going to shift to threat of antimicrobial resistance. So Dr. Marazza already mentioned this briefly. Essentially what we have, of course, is an increase in rates of drug-resistant gonorrhea, overall 550,000 cases, and then we have an increased concern from a national standpoint regarding the threat of Mycoplasma genitalium resistance. So these are some data from the gonococcal isolate surveillance project. This is a well-known surveillance project for gonorrhea that we have in the US. This has been in place for many years now. And what you can see is that obviously our concern is ciprofloxacin resistance, because remember, maybe 10 years ago, that's what we were using as primary therapy. So resistance is now about 40 to 50%. And look at tetracycline, so that's 20%. That's probably probably gonna double or more as we continue to use doxypap. So, stay tuned. As Dr. Marazza said, we have to see what the untoward consequences are of doxypap. Clearly, its, efficacy for prevention of gonorrhea is probably very limited, considering that we already know about the resistance issue. And then let's go a little bit further into azithromycin, which you can see there, essentially continues to increase. So what we have, of course, this is national data overall, and this is again from the GISP study. So they were really primarily focusing on the first 25 urethral isolates selected from, let's say, 30 cities in the country. Just wanted you to know the limitations of that data is focusing on men and just urethral isolates. But what you can see is increased MIC to azithromycin, which we have the breakpoints at greater than 2. So roughly it's fairly small here, maybe 5%, but increasing. But please note that the rates of azithromycin-resistant gonorrhea is even higher among certain populations like MSM, where it can be up to 25%. Okay, so what about Mycoplasma genitalium? So this is an important emerging pathogen, but it's not really new. It's been around since the 1980s. So this is a very nice study that was supported by Hologic. Lisa Manhart from University of Washington led this study where they collected specimens, remnant specimens that were tested for gonorrhea and chlamydia. So they tested 1,700 specimens, and what they found was they found a high proportion of MGen prevalence. So 18% among all women, 15% among asymptomatic women, 21% among women with vaginitis. And then you can see sort of the co-infection proportions there. And of course, macrolide resistance, very high, 57% among all women tested. They did not include ciprofloxacin resistance here, but we know that that's also increasing. But of note, please remember that currently there's no recommendations for routine asymptomatic screening for Mycoplasma genitalium because we just don't have enough data yet. Okay, so this is just a reminder of where our STI guidelines have changed. Due to the fact that we had this increasing concern about azithromycin resistance, we no longer use azithromycin. For chlamydia, the reason why we shifted from azithro to doxy is due to the fact that there's been studies that have shown that doxy is more effective for rectal chlamydia. And obviously for gonorrhea, we've increased the ceftriaxone, although we don't see a real markedly increase in ceftriaxone resistance in the US. It is definitely a concern worldwide. So we've increased from 125 to 500, and azithromycin is no longer recommended as part of dual therapy. You can also use doxy if you're concerned about chlamydia co-infection and cannot rule that out. Okay, so one of my favorite journals, back when I could really read well, basically is the National Geographic. So I still have those old National Geographics, and they're concerned about STDs. So they say it's at a shocking high rate. How do we reverse the trend? Well, there's many challenges. I've already touched on several. So we talked very briefly about stigma. We know that there's a very palpable, challenge of stigma that occurs mainly in the South, also among LGBTQ populations. We also have the racial and health disparities. I already showed you an example for syphilis rates occurring among Native Americans, American Indians. Then there's the burden of asymptomatic infections, which I've discussed. There's also the issue about antimicrobial resistance, suboptimal therapies. There's a lot of concern about how do we treat pharyngeal gonorrhea, as well as the Mycoplasma genitalium, which is now also developed resistance to moxifloxacin, fluoroquinolones in general, which is the second-line therapy. There's a limited, at this point, uptake of HPV vaccine. Hopefully that's increasing. And then HSV vaccine, there are, I know, in clinical trials currently. And then, of course, those of us who've been supported by the NIH STIs Cooperative Research Center have been focusing, of course, on chlamydia, gonorrhea, and syphilis vaccine development. And then there's, of course, the challenge of the federal funding, but Dr. Marazzo, gave us some great news today. Hopefully that's changing, and I think that was due in part to the pandemic and the effects of moving funds, shifting from the pandemic back to things that continue to create a challenge for us, like STIs. So we're just talking about the tip of the iceberg, really. So what are the next steps? How do we deal with this ongoing epidemic of STIs? So fortunately, a lot of the experts came together. The National Academy of Sciences, Engineering, and Medicine came together, including my boss, Mike Cohen. So these are the next steps. So these are big picture steps. So the first is to embrace a sexual health paradigm. So what does that mean? So that means we as STI clinicians need to think more in the context of sexual health. So the World Health Organization defines that as a state of, let's see if I can remember, physical, emotional, mental, and social well-being in relation to sexuality. So it's not just the absence of an STI. So we also need to look at ownership and accountability for responding to STIs. We also need to look at our existing systems and infrastructure. And then we want to embrace innovation and policy change to address these challenges. So these are just an example, recommendations for existing programs and systems. Obviously it's like maybe a 500-page book. There's a lot of content in there. But I just, took ones that I thought we need to just consider as a group. So one is, of course, expanding the STI workforce. So this is what we're doing today. We're talking about STIs in this forum, and I'm really, excited. It's my first time at ITSOG, and just really excited about the group and discussions we've had surrounding this. We also need to look at STI workforce capacity and capability to share our expertise with our primary care providers. And then we need to prioritize research in critical areas. So this includes point-of-care diagnostic tests, specifically quoted in the Sexual Health Paradigm book, is looking at challenges regarding distinguishing treated syphilis from persistent antibody response with our serological tests. So that is considered a priority. And then, of course, we need to subsidize and encourage public-private partnerships in order to come up with novel therapeutics, given the fact that we are having this shrinking, antibiotic choices, especially for gonorrhea, mycoplasma. And also we need to look at, partnerships to move the vaccine development research forward. Okay, so what's the take-home message? Well, I want to just leave you with a very simplistic message, but effective one from the CDC. So STIs can be prevented. If you talk about sexual health, you want to have these open conversations with, every sexually active patient that you see. We need to reduce stigma. We need to normalize it. So we also need to test. We need to test frequently, think of the syndrome, and as well as think about appropriate treatment following STI treatment guidelines. And also I know that there's ACOG guidelines. And then last but not least, what can we do? Well, let's take the message from Rosie the Riveter. Again, I told you I love vintage posters, so we can all roll up our sleeves and get our work done. Hopefully, we can reduce STIs by 2030. Thank you very much.
So in my session, I'm going to focus a lot on STI co-infections. We're going to review pre-NATS data on the relationship between STIs and vaginitis, and there is a lot of data out there. Some of it is older, and so some of you younger folks may not have run across it yet, but I implore you to take a look at it because there's a lot of interesting prospective studies out there, and I'll cite just a few. Then we have new data from an STI co-infection study with vaginitis that I will go over with you. And finally, I'm going to propose a possible algorithmic testing protocol for STIs in women with vaginitis. This was a few of the studies that I wanted to share with you about interrelationships of STIs and vaginitis before the era of NATS testing. And this was a study by Dr. McClellan, who is here in the audience, and it looked at infection with trichomonas as an increased risk for HIV. And so this was a prospective study, which is really what we want to see, and they enrolled numerous HIV-negative women. They were really looking, I think, and Scott can correct me, the primary outcome was probably HIV seroconversion. But they found, interestingly, that these women were also, the women with trichomonas had an increased risk of HIV acquisition. So this was one of the issues that they found, and I think this was a very important study. And then kind of looking at it from the opposite point of view, transmission of HIV. So Scott's study was acquisition. Transmission of HIV, this was a small study where they looked at HIV RNA in genital specimens, and these women had trichomonas as well, and they looked at pre-treatment viral loads and then post-treatment for trichomonas viral loads. And you can see there was a remarkable difference. So I think it works both ways. With many STDs and HIV, it's acquisition and transmission. BV, that's my favorite, and here you know all about that. BV, I mean, we're still fighting over what causes it. Personally, I'm convinced that it's a sexually transmitted infection, and I'm also convinced that Gardnerella is the keystone pathogen, and that women probably acquire Gardnerella through sex, And because Gardnerella is capable of changing the environment in the vagina in terms of decreased redox potential, increased pH, you get the abundance of anaerobes that come along with the condition. And we heard, I think it was yesterday, about how the anaerobes are certainly responsible for causing the distressing odor that women can experience with BV. So just in summary, before I get to the newer data, in terms of STIs and candidiasis, there's really no apparent relationship when you look through the literature. And to me, this makes a lot of sense, because if you look at a gram stain of a woman who has only VVC, you'll see that she still has a mostly lactobacillus predominant environment. And also that means she has a relatively acidic pH. So we know that those are some of the protectors against STIs. Trichomonas, of course, trichomonas itself is definitely an STD. And then BV and STIs, this has definitely been a risk factor, and we've shown this before in the older literature for acquisition of STIs. And then this was just another little vignette I wanted to share with you about the relationships in this time between BV and an STI, particularly chlamydia. And I think we had a presentation about this before, yesterday, about the mucosal sialidases and glycans and things. So there obviously are different mechanisms involved. But this was a small study that we did. It was a trial of BV treatment, and we did weekly prophylaxis because we all know, that BV tends to recur quite a bit. So we wanted to keep the flora during the course of the study as normal as we could. And so we had a randomized to treatment versus observation. And there was a significant difference in the rates of chlamydia between the two groups, as you can see here. 8.6% chlamydia infections, this is prospective, in the BV treatment versus 27% in the observation group. Again, it was a small study. I think studies like this need to be repeated. And then we've also learned since then that there's an interrelationship between indole production by the anaerobes that are common in BV and utilization of indole by chlamydia. So again, there's probably multiple mechanisms involved. Okay, so this is the newer study I wanted to share with you. This was a study sponsored by Hologic. They had numerous US sites. They enrolled over 1,500 symptomatic women. And they collected, you can see here, it was a nightmare of collection. Swabs were flying everywhere in the clinic. So they had clinician, collected swabs, self-collected swabs, everything. And they wanted to compare, and this study was specifically to look at gnats for diagnosing vaginitis, okay? And they wanted to compare what they did then. They took remnants of these vaginitis swabs that had been tested by gnats at these sites, and they then did STI testing. And they compared the STI testing, which was done by gnats, to two parameters. One was the clinical diagnosis of vaginitis data, which they had collected at the time of the study also. So that means, wet prep or looks like that. And then they also compared it to sort of the routine, the next level diagnostics. So for BV, I think it was AMSL plus Nugent score. For trichomonas, it was culture. And for yeast, it was culture and sequencing. So they looked at those two things. This is just a pie chart that shows you what they found in the vaginitis study. Again, things that you would particularly expect. Again, this was with gnats testing. So a lot of BV, a lot of mixed infections, which I think is something we miss when we're doing wet preps. It can be easy to miss that because you say, oh, I see a trick, next on. So, we do miss a lot of that. So the question to be answered was, what is the STI rates in each category? As I said, it was remnant swabs from this vaginitis study, and I already mentioned the things they compared it to, so we'll skip that. This is looking at Aptima Gnats STD prevalence by clinician vaginitis diagnosis. And some interesting things here, I think. You can see the combinations there, BV positive, CV negative, CV positive, et cetera. They found that 45% of the STIs that were diagnosed in women were with clinical-based BV diagnoses. That's a lot. And 93% of these were MGENT and TV, to be fair. 1 in 4 women with the clinic diagnosis of BV had an STI versus 1 in 10 women with a clinic diagnosis of yeast infection. So quite a difference there. And that gets back to the slide I showed before that confirms that earlier data. And then this is the same sort of thing looking at the diagnosis by the routine laboratory, well, it's not routine, but the higher level laboratory diagnosis. And if you look at this data, you can see that if BV was positive, was present, you had significantly higher rates of MGENT and chlamydia than you did if it was BV negative. And this played out throughout the entire study. Gonorrhea, unfortunately, well, or fortunately, there were very few cases of gonorrhea in this study group. So it's sort of hard to draw conclusions about that. Although it did show up as significant with trick infections. And that's something that years and years ago at CDC, Joe Losick, I never met him, I always wanted to, showed in one of his studies that there was certainly some concordance between trick and gonorrhea. This is just, your favorite Venn diagram. But you're looking at BV positive women, 518, versus BV negative women in this vaginitis study at 533. 26% were positive in the BV group for STIs versus 11.1% in the BV negative group for STIs. And you can see the p-value was pretty impressive. Now you know why I like BV. This I thought was kind of interesting because, we assume that we know normal is normal and we know BV is BV, but that intermediate group, we're not quite sure what to do with that. But the fact of the matter is that it is potentially a risk factor for STI acquisition as well. And in fact, many years ago, our group showed that cytokine levels increased as soon as you reached Nugent score of 4. So as soon as you got out of that normal range, you were kind of at risk. So this is just a summary of what was found. You can see the different, again, categories. And again, basically, if you look at any BV positive versus any BV negative, there's an increase in terms of the STIs that were found. This is the risk-based diagnostic algorithm that I sort of came up with. And this, Hologic had nothing to do with this, believe me. But I wondered if, kind of like the reflex testing we do for syphilis, I wondered if you sent a NATS, anybody's NATS, for vaginitis testing, and it came back positive for BV or trick, could that same sample be automatically reflex tested for STIs? That would make the whole process quicker. It would make it more efficient and hopefully find more cases of STI. Of course, you're still going to do an STI risk factor assessment, so that comes into the model as well. But just a thought I had, and I think it could be something that we should look into. So, like I said, Dr. Sanya, I hope revved you up. You know, it's been very disheartening for me to see the lack of support for public STD clinics, including the lack of support for the STD division at CDC. It has really, to me, been incredibly disappointing. And when I say lack of support for STD control, I'm talking not only about the clinics themselves, of course, the clinicians who treat the patients, and the disease intervention specialists who do the contact tracing and are really key in a lot of these investigations. You know, there's this political element. STDs don't affect nice people who pay their taxes. Well, of course we know that that's a myth. And even if it were true, those nice people, we're all paying for it at some price, in some way. This was, so many years ago, I think this was at IDSA, I don't remember which one. I was pretty young then too. But Dr. King Holmes gave a talk, and his last slide was this slide. Access to care, quality of care, does anybody care? And that really hit home with me. And I hope that if for no reason other than your respect for the hard work of STD control specialists, clinicians, researchers, DIS, that have come before us, I hope you take this charge to heart and do the best you can to try to, and I'll say eliminate STDs. Thank you.